the tips to successful type 1 diabetes management. Now, I thought of how will we go about this, and finally felt that let me share a few tips for people who do not have exclusive type 1 care centers, because that is something where everything is already existing. The whole ecosystem for type 1 care is existing. So my thoughts were this, to share what a doctor can do. So my talk is from a doctor perspective in ability to provide successful type 1 diabetes management to the children, adults, and their families who come and visit them. So it's an art and a science. On this screen, you see Sanika. She was 10 years old when she had type 1 diabetes. Today, she is a diabetes educator. You can see how proudly she shows off her device to monitor her CGMS sensor. But we realized over time, as everyone has realized, there is a lot of science. We have just seen the technology session. Wonderful technology has come in, but there is also a lot of art. There's a lot of soft skills involved, and hence the education, motivation, counseling are just as important as the insulin technique and regime, the pumps and the CGMS, and the carb counting. So we have come a long way from a chapter in a book 20 years back in medicine to what we see, hear, read, understand today. But that merger, the art part, is something that we still have to learn, without which the science does not manifest itself. So my first thought here is the approach, the doctor's approach. Whosoever, it is not about resource limited. It is not about being in a, maybe if you are in the best setup in the country, in the world, yet what is the doctor's approach to T1D care? So unless and until our approach starts with empathy and then steps on to a willingness to engage with the person and the family who steps into our consulting, and with the ultimate goal to empower our patient and their family. So I believe, and this is not just a belief, I'm sure everyone here will endorse who is working in type 1 diabetes, that unless we are empathetic in our approach, unless we are willing to engage, and unless we are now willing to empower our patient, because the olden days, it was a very glucocentric approach. It was an approach of, I am the doctor, you are the patient, I know, and you listen to me. And there is no such thing in type 1 diabetes. We want to empower them so they don't need us anymore. I mean, that is the ultimate aim, that they can take care of themselves. And the picture here is the first one-up challenge that was done for Kalsubai Peak from the students all across the country, and they made it because they were empowered. So first tip for a successful care, I would say, is create a team. Even if you have a very small clinic, if you have a very big busy practice, it is not possible to take care of type 1 diabetes without having a team. Because if you are going to see, if I am going to see my patient in 5 minutes in a busy OPD, then wherever there is no team, there could be different ways. We need a nutritionist, a qualified nutritionist who knows what is type 1 nutrition care. We can have coaches who, if we have more patients, we can have somewhere a bridge between the educators, doctors, and patients. And we can have leaders with type 1 diabetes who can be part of our team. So sometimes nutritionist, educator, counselor are one person rolled into one, which is fine. As long as we keep on learning, we keep on upgrading ourselves, we are scientific as well as in our skills to counsel are updated with learning in our peer group. So leaders with type 1 diabetes, I would like to add here, or their family members, make wonderful educators, wonderful counselors, and wonderful support team. So these are people we can actually structured way, we can teach them, we can involve them, and they can become a great team member for us, where in every case, even if we have professional qualified people, they must be a part of our team. That is one successful mantra for having good diabetes care. Then we need to maintain an inter-visit communication channel. So I am just giving little tips of things which we often miss. Everything else everyone is doing. So I'm not talking about that. So what happens between two visits? The official guidelines are visiting, but often the visit can be even a longer time because, say, in COVID times, they were not coming in early enough. Then how do you communicate? And 3 months is a long time to follow up. No way they can reach us or we can reach them. There can be a loss of motivation or care, or things can be missed. So there are various things that can be done in times of technology today. The simple things are can be helplines. These can be 24/7 phone numbers that an educator can run or a type 1 leader can run. There can be WhatsApp groups which are seen at specific times so that they do not disturb us, and they can be groups of same age related or that village related or that town related. Some way we can put them in a certain group, or just boys or just adolescent girls or something, whatever criteria we want to use. They can be a buddy who can be assigned, a type 1 leader who is willing to just go in a rotation duty, saying that I'm available from 4 to 8 every day. If you have a problem, call me. So these can be buddies. These can be mentors. These can be coaches. We have an hour of online type 1 meets every day, and that is how Udan, my organization, is reaching out to the remotest of village, because even when they're sitting on the bullock cart under a tree, they have a phone which has internet on it. So that is the biggest technical advantage today that has helped us to train our patients, stay connected and keep motivated. And social media, especially for youngsters, is extremely motivating. Hence, it's not showing off. It is actually a big motivator to hear success stories and share all kinds of training, teaching. YouTube videos can teach in every language. You can reach every corner. So maintaining an inter-visit communication channel is very, very important. It can be a very humble helpline to a very complex site or technology. Another small tip which I would like to add here is maintain documentation. Often we talk to people who have a lot of children who have seen adults with type 1 diabetes who are taking care, but they do not have a structured documentation program. And then either we lose out, we have loss of follow-up, we don't have data, we cannot take care of them because the last data is lost. And so many patients we know are very careless and they don't have their reports, etc. So a good registration process with all the details, including permissions. So that is one tip. Do take permissions from our patients, that if you want to use their photographs, if you want to use their data, if you want to be able to call them, because they can take objection to even being called. So anything, take all the permissions, take all the due form and all the information needed. And then we need to maintain documentation for investigations part, of course, as a follow-up, because you want to know how it is progressing and you will want to be able to look back, as well as the clinical, say the growth chart, the blood pressure measurement. So everything, it's very important to have a documentation. Very good softwares are available. I'm using a very simple one which helps me on a click. It's on my phone, it's on my laptop. Anywhere in the country I am, in 1 second I can see the data of all my 900 children in 1 second. So I think that is something we should all do. Now coming to what can make a big difference. So out of hundreds and thousands of things which my dear friends here will be sharing, I'm sharing one important thing which I felt is focus on the first month. A person who comes with newly diagnosed type 1 diabetes is vulnerable. Their family is vulnerable. They are traumatized. They have actual lot of blood sugar fluctuation because they have come after an infection or newly detection, and the doses are not yet settled. So they may be on very high insulin doses which reduce later, vice versa. So it's very important that our first month is the intensive phase, you can say, of care, not of treatment necessarily, but of care. So busting the myths around type 1 diabetes in this time, emphasizing on insulin always. We all know that we are talking about a lot of social media campaigning where insulin can be stopped and people flock there and sometimes are at the risk of losing their life. So that is the time to emphasize that never are you to stop insulin. Then also address honeymoon phase in the first month itself, because if they land in the honeymoon phase and requirements go down, they're very susceptible to all the alternative therapies. So we have to warn them against them. And again, perfecting the insulin and monitoring techniques in the first first month, managing hypoglycemia and looking out for anything that we can miss, all the comorbidities in the first month, so our patient gets worked up, and individualization of a treatment. Because we will come to know whether the patient comes from a low socioeconomic group, patient has literacy issues, access issues, family environment, whatever it may be, doesn't matter. Or everything might be just great, might find a very intelligent child. The level is so high that we can offer them more. So the first month, I would like to emphasize, is a very important time. Please take out time. If we do not have time, please see to it that someone who has time sees to them, because once traumatized, that impact can last a lifetime. So hand holding for the first month gets to be very warm, very soft, and very, very special. And that will set the tone for the entire diabetes management for the rest of the child's and the family's life. So individualization of care is the next thing. Every person who walks in is not the same. They will need insulin, yes. Principles are the same for everyone, but which insulin, how, what device, what method? We have to individualize. Monitoring, physical activity, follow-up and investigations, availability, affordability, accessibility, emergency care, and medical nutrition therapy. So these foundations of care have ultimately in the center education, education, education. So that is the pillar on which everything is based. But we have to individualize this. This is what can make a very good care method if we individualize the treatment. And I'm going to talk about that very briefly, each one of them. I'm not going to go into the insulin regimes, but I want to really emphasize that we have options for everyone, from the humble regular insulin and NPH to be used as a split mix regime, to the basal and bolus, and of course the insulin pump for all who can. Let's offer them, everyone who can. Let's not deprive them thinking they can't. I know patients from villages who said, ma'am, offer us the pump, we'll have it, we'll find a way, we can get it sponsored, we can get it from the MLF fund, we are smart enough. And sometimes we over or underestimate our patient. But if all those things, we can make all kinds of regimes which, using regular and NPH, if there is no affordability and accessibility of basal and bolus analog insulins. So mix match as per the need regime can be created in every clinic everywhere in the country, but no premix insulin, please. It is, in a growing person with type 1 diabetes, it is not what we want. We do not endorse premix. It is either a 30% or a 50% formulation, and both of them give us inadequate short acting, and there's no flexibility. We know all the harm that comes in. It's not covering the lunchtime. There's so much of glycemic variability. I know it's easy, it's convenient, but at least in that case, one can go for regular and NPH. Suppose it's better than dying, I agree. If there's nothing else, regular and NPH, at least the doses can be taken. So let's give everyone option with the basic to the best insulin with interesting regimes, because we know the physiology. Let's make it happen. Let's offer the pump to everyone, and no premix insulin, please. Next comes the monitoring. So we all know we have to do it. It has to be logged. I just want to say that we all know the 8 sugar pattern. We know it should be done, but create your own patterns. That is what is the secret to good care. Learn, and there is no point in just checking if we cannot interpret them and take action. So the action can be point of time, which the family has to learn, or the action can be seeing a pattern over a couple of days or a week. And that an educator can help. It can be messaged, it can be mailed, or it can be met. And then the pattern can show them how to set the doses. So either way, unless we learn. So I have demonstrated a pattern I call 3+7. So 3 sugars every day and 8 sugar one session, willingness, and how much the child needs. At some stages, they may need more monitoring, sometimes less. But create your own pattern which suits them. Have a dialogue, set that pattern, and make a pattern which is individualized as per the accessibility of the strips. But there is with insulin without monitoring is absolutely it's hardly a treatment, right? So when we talk about insulin is essential, we also talk about monitoring is essential. So we can tailor make it for anyone we can, and whoever can should have a CGMS. We have so many things like the Libre Pro to the everything. So all that technology session is going to be there. So I'm not going to into it, but I'm just saying for those who have not used, at least try it once. It is just such a wonderful learning curve that one has. Continuous use is wonderful, but also intermittent use, maybe once in 3 months to set the pattern by the doctor, can be amazing. There is an insight, you can fine tune the care, and the person who uses just has an eye opener. They know what affects their sugar, what activity, what food. I mean, you can tell a doctor something else, but a CGMS is going to tell the truth to one own self, and that is a wonderful motivator. So it gives a lot of flexibility. One can play, sing, dance, whatever, and it really gives them flexibility. And that's something, please try. Whoever hasn't, at least try once. So this is just one of my little girls who is on a CGMS, and look at their smiles. I mean, they were so happy that all the little ones, I just want that to happen. So next topic, we all talk about, it's tough for doctors if you don't have a nutritionist. So nutrition is a very vital topic. We have to learn. There's no choice. So balanced plate is the first basic thing. Identifying macros that everyone can learn. People who cannot do actual carb counting because of literacy issues or IQ issues or anything can do visual carb counting. Then actual carb counting has to be learned. It's so difficult. It took me so long to learn it. It was tough for me, but ultimately I had to, because I have to communicate with all the children and their families. So I had to learn it. So that is very important. And ultimately one can do a self meal planning, carb counting, dose adjustment. We cannot skip this chapter. Absolutely, we cannot. Maybe there can be levels, but we cannot skip it. So every family can learn to eat healthy, can monitor, can adjust doses as per the nutrition, can do carb counting at certain level. For example, this is little Sapna, and look at her plate. It is well balanced. She can do visual carb counting. She knows that her chapati is of 1.5 carb count. She knows how much that dal is. So she balances her plate and she knows visual carb counting. Otherwise, she cannot, because they're all literate. One very important topic is follow-up. So we can't just treat and let them go. So whichever guideline, I'm not going to go into this table, and this is the ISPAD guidelines of follow-up at 3 monthly level, micro, macro, autoimmune, psychosocial, anticipatory guidance. Please go through it, whichever guideline you follow, or make your own protocol, but there has to be a follow-up structure and screening. So these are some of my children who at regular intervals at various places will go step by step and get the screening done. I won't call it last, but yes, the most important is education and its tools. So we can give them basic education, we can give them comprehensive and advanced. Whoever feels I don't have a team, at least go for the basic first. Take time, next level is comprehensive. And then of course with technology, we can go into advanced. But every person can be and must be educated irrespective of literacy status. There are many tools. I mean, there are many, many tools, and whoever is willing to learn, I cannot speak here, but there are a lot of ways one can do that. And Shuchi is one of the best designers for many of these tools. And these are some handmade tools that we use, like games and board games and pins and playing cards. So many things one can do. Again, amongst the tools, it is the earthen pot in which we store insulin. So everyone has their own way, but I'm just saying, if you do some jugaad, there is so many ways of reaching out to children. And this is my last point, which is peer group activity. So please introduce people with type 1 diabetes to experience. These are experienced champions, and they make motivated educators. And that experiential learning works way beyond what we teach. So this is a very essential. Every child says, I'm the only one in my village. And when they know other person, they feel very good. So this is where people bond. And the only bond here is that we all have type 1. So they're on top of the Altabad Killa and they're so happy. They learn, they are motivated, and they get better. It is still easier than said than done. We try to learn, and this is what all the calculations, which all everything looks like. It is so, so tough. We know, but we also know that we can do it. So every child deserves the best to lead a fulfilling life, and we can do it with some basic steps and structure in place. And that is my message, that do not skip any step, innovate, improvise, Find a way to do it, create your own teams, but do not skip any aspect of care. Wherever you are, reach out to an organization nearby and then do it. But do it. Do not leave a step unturned. Thank you so much.